And welcome to Healthline 3, everyone. I'm Johnette Magner. Today we are talking to Dr. Donnie Aultman. He is a surgeon with Willis Knighton Health System and the Willis Knighton Advanced Surgery Center. He does many different things, including transplants, but today he is here in his role as a thyroid and parathyroid surgeon. And of course, we will be taking your calls throughout the 30-minute show. And as a reminder, please make sure that you are in a quiet room when you call with your TV turned all the way down. Otherwise, the call doesn't work very well. Our number is 318-219-4569, and you're going to see it throughout the show on the bottom of the screen. And so if you do call, don't forget that you get to talk directly to Dr. Aultman. You can talk to him about your particular case. You can ask him any kind of questions that you have and share your concerns. So welcome, Dr. Aultman. I hope you're ready.
I'm ready. Thanks for having me.
Okay, well, let's start with, we have many different systems in the body. And of course, most of us understand the digestive system and the circulatory system. But the endocrine system, not so much. Tell us what that system does.
Well, the endocrine system involves many different organs in the body. The ones that people would be most common with, or the one would be thyroid, probably the most common one that is dealt with from a medical perspective. But we also have the parathyroid glands, we have the adrenal gland, and we have the pancreas, which makes insulin to keep us from becoming diabetic. So there's many organs that are considered endocrine organs and perform an endocrine function in the body.
And you work with all of them, correct?
Pretty much all, either with the transplant or with the surgery. The surgeries I do mostly involving thyroid and parathyroid, but in my group we do have surgeons that do the adrenal surgeries robotically, so you don't have to have the big cuts anymore, use the robot.
Wow, that's really impressive. So start though by telling us more about the thyroid itself, because, well, where is it? Yeah, and what specifically does it do?
Yeah. So I think most people understand the thyroid. The thyroid sits right here, sort of in the lower part of your neck, right on top of your windpipe, and it sort of drapes over the windpipe with half of it on one side and half on the other. The thyroid will function to do lots of things. It will control your metabolism, so it can control your weight. It can control your heart rate, sleep patterns, many functions in the body that the thyroid will do.
The times when I hear someone talk about their thyroid is usually related to weight. They can't lose weight, or they've suddenly put on a lot of weight, and then they go to the doctor and it's like, my thyroid, it's my thyroid's fault. How common is that, and can adjusting the thyroid really make a difference in your weight?
Well, I have patients come in and they say, well, if you take out my thyroid, am I going to lose weight? And that's really not the case in most instances. Your primary care doctor will check your thyroid levels. If your thyroid levels are normal, it's highly unlikely that that relates in any way to you losing or gaining weight. Now, if you become hypothyroid or low thyroid for whatever reason, and there's multiple reasons for that, then you can develop weight gain, and that is something that you need to look at. And if that's the case, you'd need to be treated with thyroid hormone taken as a pill to supplement your thyroid levels.
So what are some of the most common thyroid conditions that you encounter? What do you see the most?
Well, common thyroid problems are going to be hypothyroid or low thyroid. You see that in a lot of cases where patients develop a condition you may have heard called Hashimoto's thyroiditis, and that is an autoimmune condition. I put it in that same category like people with lupus or rheumatoid arthritis, for which the thyroid gets attacked and the thyroid doesn't function properly, so they get low thyroid levels with that. The other thing you see is hyperthyroidism or high thyroid, and also could be known as Graves' disease. And people can develop that and need to be treated with that. Surgery is one of the options that is available for hyperthyroidism. I think I most commonly see patients for surgery that either have Graves' disease, hyperthyroidism, that has been recalcitrant or not affected well with treatment or medication. But most commonly I see patients with thyroid nodules. So they have found a nodule in their neck. They are interested, is this cancer or not? And so those are the patients that I see probably most commonly for surgery for the thyroid.
All right, well, we have a caller already on the phone. Michelle, welcome to the show. Please ask your question.
Hi, I wanted to ask a question. I've had hypothyroidism for several years now, and I see an endocrinologist, and I'm on levothyroxine, which is the medication for it. And I just had blood work done, and my doctor states that my blood work is within range, so he wants to keep me on the same dosage that I've been on. However, I've been having all of the symptoms that say that I have hypothyroidism. It's like not, I guess not, I'm trying to think of the word. Like I still have all of the symptoms, like my medication is not taking care of all the symptoms. So even though my blood work states that everything is okay, my symptoms are all still there. So what would you suggest in that situation? If I'm still having all the symptoms, but the doctor says, okay, the blood work says it's okay, but
yeah,
what do I do then?
That's an interesting situation. And you know, sometimes we will see that where the blood work looks normal, but the patient may still have fatigue, just feel bad over time. And you know, I don't know, I'm sure they may have checked you for Hashimoto's thyroiditis, as we were just talking about, but that is a condition where even sometimes with your levels being normal, it can make you still have some symptoms of fatigue and feeling bad. So you may just ask about that to see, did they check your levels for or antibodies for Hashimoto's thyroiditis?
Okay. I will definitely take note of that and definitely do a little bit more research because I definitely know something is wrong with my body. I mean, I have severe aches and tenderness everywhere, muscle weakness. I mean, it doesn't matter how much I try to diet. I cannot lose weight within like a 10-pound radius. Like just completely fatigued. Everything is messed up. My sleep pattern is messed up. Everything is messed up. And I don't know what is going on. But, you know, you feel like something is wrong, but you can't put your finger on it.
Well, I think just check into that and ask. They hopefully would have checked that and give an idea. But some of the things you're talking about are some of the things that we can see in patients who have Hashimoto's disease.
Okay. Well, I really appreciate your time, and I'll definitely do more research and make another appointment with him to discuss this further.
All right. Well, thank you for calling in.
Thank you.
Yes, thank you, Michelle. And to anybody else who's thinking about calling in, here's the number on the screen. Let us remind you, it's 318-219-4569. So please give us a call and ask your questions. So I have another question for you, and that is, do people ever have thyroid problems and they just don't know it, and they live their life for years not realizing it?
I think some do. Some may have some mild low thyroid or just mild high thyroid and may not have many symptoms from it and may not know it. And that may not necessarily be clinically significant, meaning it may not be extremely harmful to them. It may be just minimally elevated or minimally low. But I think the thing that probably they may not know about would be having a nodule in their neck. And that they may not know that they do have a nodule that's come up in their thyroid, and they may go many years, and it may be they can't see it, they can't feel it, but they get some other x-ray test. For example, they go and they get a MRI of their spine to look for spinal disease, and the MRI says, oh, we see something in the thyroid. I see a lot of those where they didn't know they even had it, and they'll come to me and say, I didn't know I had this, but it shows up on another scan. And then we have to work it up from that point. So yeah, people can have problems and not know about it for sure.
Now, when you go and you get a physical and the doctor starts feeling your neck, is he checking the thyroid too?
Yes, okay. Absolutely. They should do a thyroid exam on you as part of your routine yearly evaluation. And again, sometimes though you may not be able to feel the nodule. It really depends where the nodule's located. It could be deep in the neck, and you just may not be able to feel it. So it's not always 100% that you can even feel a nodule.
So all of these various problems and issues that we've been talking about, how are they generally treated, and when does someone get to the point where they need you, the surgeon, to actually do something?
Right. Generally for the low thyroid, that's treated by the primary care or endocrinologist, where they just treat them with thyroid medication, and that may never require a surgical visit. The hyperthyroidism or the Graves' disease, that again can be treated medically, can also be treated with what people have probably heard of, radioactive iodine. So you can be treated with that, and sometimes that will ablate or kill off the thyroid so that the Graves' disease or high thyroid disappears. Now, in some instances that does not work, and I've got a patient tomorrow that I'm doing surgery on that had the iodine and it just didn't work, and so we're going to do a thyroid surgery and remove the entire thyroid in that case. Also, I generally see patients who come again with the thyroid nodules. And the first step in that, in many instances, is to do what we call an FNA, or fine needle aspiration biopsy. That's done with a very tiny needle put into the nodule in the thyroid. Cells are withdrawn. The cells are looked at by the pathologist. And then the cells are sent away for what we call genetic testing. So that genetic testing looks for different, what we call mutations or changes within the cell, to help us identify which have the higher risk of becoming cancer, or is it cancer. So that's sort of, I see the majority of patients are going to be those type patients who come and have had a biopsy or even need a biopsy.
When I think of things like breast cancer, one of the first things a doctor will ask you is about family history. Do thyroid problems, are they predictable or more likely if you have a parent or a sibling who's had problems?
That's a very important question to ask. So if you've had first degree relatives who have had thyroid cancer, that has to be put into your equation when you're deciding, should this be biopsied? Should we go ahead and do thyroid surgery? So definitely family history does play a role in that. Now, there's some other thyroid and parathyroid conditions that are actually genetic within families, so that if a family member has it, it's what we call a dominant trait. It will be passed on to numerous other family members. And you may hear it on some of the ads on TV where they talk about multiple endocrine neoplasia syndrome type 2.
We've all heard those ads.
You'll hear that with Ozempic and such. You'll say you should not take this medication if you have a history of medullary thyroid cancer or multiple endocrine neoplasia syndrome type 2. So that multiple endocrine neoplasia syndrome type 2 involves parathyroid, the medullary thyroid cancer, and a tumor in the adrenal gland called pheochromocytoma, which causes bad high blood pressure. So that's I'm sure people on TV have heard those terms.
We've heard those terms, but I'm really glad I'm not the one having to say them. I'm glad that you're the one doing that for us. Okay, so let me ask kind of a simple question here. But if you remove a thyroid, I mean, obviously it does something. Yeah, I know you can remove a gallbladder and you do just fine without it. But if you remove a thyroid, does it, what do you do to replace what that thyroid did?
Every patient who has a total thyroidectomy, meaning the whole thyroid is removed, would need to be on lifelong what's called levothyroxine is the generic name. The trade name is called Synthroid, and so you would need to take that every morning for the rest of your life. It's one time a day. The dose is based on your weight, and so it basically provides the thyroid hormone that your thyroid would normally make, and it works very well. Okay. If you put 100 people out here and 50 of them had their thyroid removed and 50 had their thyroid, you wouldn't be able to know which by asking them symptoms and stuff, because they wouldn't have it.
And I guess life expectancy with this medication is the same as if you had your thyroid still.
Absolutely.
Okay, well that's really good to know. Now let's move to thyroid cancer. How much of that do you treat and see?
A lot.
Really?
A lot. It's that's the number one reason that we do thyroid surgery for nodules, is to rule out cancer. Those tests that I mentioned, the genetic testing, has really helped us out a lot recently on giving the patient, I think, an accurate or more accurate risk associated with the nodule itself. But we see thyroid cancers. There's 4 different kinds of thyroid cancers. One most common called papillary thyroid cancer. Second most common called follicular thyroid cancer. Mm-hmm. Then the third is medullary cancer. That's the one associated with the multiple endocrine neoplasia. And then the fourth one, which is the worst of all, is called anaplastic thyroid carcinoma. Now, patients who have the papillary and follicular, those are very good. I tell people, if you want to pick a cancer to have, pick a papillary or follicular cancer. If you got to pick a cancer that you got to have, pick one of those, because patients with surgery do extremely well. Mm-hmm. The cure rate is almost 100%. Patients, the 5 and 10 year survival rates with those is 95+%. So people do extremely well with those. When you get to the medullary cancer, it's a little different. And let me go back to the papillary and follicular. If you have those and you take the thyroid out, most patients after that will get radioactive iodine dose from at least the papillary, okay, and follicular from their endocrinologist. Okay, that helps if you happen to have any other thyroid left in the neck. Even a little tiny piece can grow back. So the radioactive iodine helps ablate any cells of thyroid that may be left around. The medullary cancer, though, you do not treat with radioactive iodine. The prognosis not as good. The 5-year survival for that's about 60%. 10-year survival drops down to probably 30 to 40%. The anaplastic cancer is the one that's extremely rapidly growing. Patients will come in and they will tell you, I've noticed in the last 3 months this hard mass in my neck, and the patients are hoarse and they can't swallow, and that's a really bad tumor to have, and the mean survival for that is less than a year.
Wow, I bet that is a really difficult thing to tell somebody.
Extremely.
And is there, for those individuals who have that, and you talk about they're coming in and they're hoarse and they've got this big mass, did they miss some early warning signs that would have made the outcome potentially different?
Not a lot of times. This thing pops up a lot of times so quickly that they probably 3 months ago may not have even known anything about it. So it's difficult.
And at that point, what do you do? What are the treatments that you can do?
Well, for the anaplastic cancer, there's really not any treatment. The surgery is not an option, because these things, it would be like you poured a bag of concrete in the neck, and it's just stuck everywhere. The only thing that we can offer is sometimes radiation therapy to try to shrink it down some. And there are some clinical trials that are undergoing where the patients can receive, you may have heard the term monoclonal antibody therapy. Certainly. And so Some centers are using this as an experimental trial, but again, nothing has been proven to really help this problem.
So when we look at these different cancers, are any of them more likely to occur in a particular gender or at a particular age?
Well, I think particularly the papillary and follicular are more common in females, and they think that it may be related in some way to estrogen production. You see papillary cancer more common in that 30 to 50 year age range. So I even have had teenagers come in with papillary cancer.
Oh, wow.
But more common 25 to 50 year old for papillary, which is the good one, one. And then the follicular, the other good one, probably a little older. It's in that 50 to 80 year old age group that we see that most common.
Okay, and it looks like we have somebody on the phone who has a question for you.
Right.
Welcome to the show, Michelle. Please ask your question. All right, let's see if Michelle, are you still on the line? Can you hear us? Because we can't hear you. Oh, Tanya, I'm sorry. Tanya. Okay, Tanya, please go ahead.
Okay, so I have a question about a thyroid. I've had it mind checked many a time, and they keep telling me it's fine, but I'm very low energy. Other things, there is a history of Graves' disease in my family, and I was just wondering, earlier today you were talking about the two things on the side of the thyroid that could be affecting things, because everything you named this morning is a side effect of what I've happened.
Yeah, what I was talking about that was the parathyroids, and the parathyroids are one on each side, lower part of the thyroid. So there's a total of 4, 2 on each side of the neck, and a lot of they control the calcium level in your blood, but they also, when patients have overactive parathyroid, you can have a lot of those symptoms that I mentioned about, which is fatigue, insomnia, bone and joint aches and pains, history of kidney stones, hair thinning out, mood swings, more sadness or easy sadness and depression. So those are things that go along with parathyroid.
Okay.
So I don't know. You may just check with your doctor. I think the first thing to do on that is check your calcium level in your blood. If it's normal, it's unlikely that parathyroid's a problem, but it's not in stone. I do have some patients come in who have normal calcium levels, but do have overactive parathyroid. So the first thing though is to check the calcium in the blood, and then potentially check the parathyroid level. You can do that in the blood.
I've had issues with breaking my ankles many a times throughout the years. I think I've broken one 14 times, so that might answer some of the things.
Well, it sure would. We do see that, we clearly know that people who have overactive parathyroid have an advanced risk of osteoporosis, brittle bones. Therefore, your risk to break a bone is going to be higher if you have, long-standing parathyroid disease that's left untreated.
Okay, so my mom has Graves' disease and osteoarthritis, or whatever that
osteoporosis.
She is shrunk. She used to be 5'7", now she's like 5'2".
Oh my goodness! Wow.
Yeah. And those could be related or not related. The Graves' disease itself would not be necessarily a reason to say that they have bad osteoporosis, and she could have the osteoporosis from other factors. But I always just say, and I think most physicians look at your calcium and parathyroid levels if you do have significant osteoporosis. Most patients, females particularly, will get bone density studies done, usually after menopause when they're concerned about that. And so you look at those studies and say, okay, my bone density is horrible. Well, I think, as part of that workup of why your bones are so bad, you would look at the calcium and the parathyroids to see if that's contributing. Now, I will tell you, there's a lot of patients who have bad bones that parathyroid has no issue with. But I'm just saying, I do think that's one thing that you do look at when patients have significant bone disease, bone fractures and such as that.
Okay, so I went to an endocrinologist about 3 months ago, and he told me that there was nothing wrong. Because my thyroid and my TSH, or whatever those letters are, were in normal range. He didn't check the parathyroid like you're talking about, or the calcium in my body either.
Yeah.
So when I return to him, I should ask those questions.
Yeah,
Is that what you're
I think
explaining?
ask those, and make sure that they understand all the problems that you've had with bone disease and such as that, and just say, do you think that there's a way that my parathyroid, could be involved? And sometimes they may have lab from another doctor or something they've looked at, and they may see that the calcium's normal, and so that's why they may not pursue it, because they may see that it was normal and it's not something that we have to really dive into so much.
Well, thank you very much for your information. I appreciate it.
Okay.
It's answered a lot of questions.
Okay, thank you.
Yes, thank you for calling in. There are with so many cancers and other. Oh, well, we have Pat. Let me go ahead, since we're getting close to the end of the show, and go ahead and let Pat ask her question. Please join us.
Hi, I'm Pat, and I've been diagnosed with hyperparathyroidism, but so far the scans are not showing any tumors or anything. So far I've done the committee. I'm scheduled now for 4D CAT scans. So my question is, even if nothing ever shows on the scans, I'm still going to need the surgery. So what's the benefit of having all the scans and trying to find an adenoma? What's the benefit?
Right. I guess the real benefit is, in many instances, the scan can indicate which is the most active parathyroid gland. Okay, so if it does that, in my surgery, I'm willing to make these what I call minimally invasive incisions that turn out to be about 1 inch long, and we can go in and literally take out that overactive parathyroid. So that's really the advantage of the scan. Now, the disadvantage of the scan sometimes can be that the scan may show one that's enlarged, but that doesn't always mean that you may not have another one that could be enlarged. That happens maybe 10 to 15% of the time. But 85 to 90% of the time, if you get a scan that shows an overactive parathyroid, that's going to be the only one that's involved, and you can take that out and the patient will be cured. You may Google parathyroid sometimes, and you see some people that will say, we don't even want to get a scan, we just go and make an incision big enough that we can search for all parathyroids. And then my argument against that is saying, well, sometimes the parathyroids can be located in very funny positions. In fact, I tell patients when I'm doing parathyroid surgery, I can cure your problem 95 to 97% of the time. I never say 100, because sometimes these things can actually be behind your breastbone, in your chest, close to your heart. And so if that's the case, you're not going to be able to see that if you have an incision in the neck. But again, I'm one where if the patient has the lab or biochemical evidence of hyperparathyroidism, I'm willing to operate on them regardless of what the scan shows, because if I think you got it, we need to try to find the problem.
All right, well, we have just a minute left. Please tell everybody where they can find you and a little bit about the surgery center.
Yeah, I'm at Willis Knighton Health System on Greenwood Road at the main North Campus. I've been at the Advanced Surgery Center. I generally take referrals from your primary care doctor or from your endocrinologist. I'll be happy to see people if your doctor wants to refer you over for any thyroid or parathyroid problem. Just ask them to send us a referral. We'd be happy to see you. The phone number at my office is 318-212-8350. But we'll be happy to help in any way we can.
And that's Willis Knighton, Greenwood Road in Shreveport.
That is correct, Greenwood Road.
All right. Well, thank you so much for joining us. I've learned so very much today, and I know that all of our viewers have as well. I hope you'll come back to see us.
Be happy to. Thank you for having me.
All right. And thank you to all of you for joining us today for Healthline 3. I hope you have a wonderful afternoon.